to have all of our participants here today. The speakers, they were very, very gracious, and the minute we asked, they said, yes, this is something we'd like to do, and they've joined us. And to start off, Gopi, can you have the first slide? So we're looking at the different aspects of practice that you can do post optometry. The first set of options being practicing, starting your own private practice. And to start off with that, we've sort of split it up into two: practicing in urban centers and practicing in semi-urban or smaller rural centers. To start off with our series today, Gopi, can you share the screen for Rekhi sir, the speaker slide? We have...
Can you stop sharing and reshare your...
PowerPoint?
Yeah.
Rekhi, your screen is stuck. So do you want to stop share and then... Yeah.
Reshare?
Yes, please. Perfect. So it is my absolute pleasure to invite Mr. Preeti Singh Rekhi to talk to us regarding independent practice opportunities in urban cities. Rekhi sir really needs no introduction, but just to complete a few formalities, my super senior at work, an independent practitioner on passing out of optometry from day one. He is one of those people who, I have patients from different parts of the country coming and telling me, "Humne Dr. Rekhi ko dekha tha." So they go see Rekhi sir and then come back, and tell us that, aap wahi usi college se hai, and it feels really nice, you sort of say, yeah, I am. So thank you, Rekhi, for, putting ESO on the map as well. And the other thing is, he actually embodies what we wanted to really push across or convey to the students: how an independent practitioner can actually create a space for themselves and do wonderfully well. So without saying anything further, sir, I'm going to hand over the screen to you. Thank you.
Thank you so much, Sharanya. Happy that in whatever little way we've been able to contribute to optometry, I've been able to do so. I still remember Dr. Badri saying, just go out and practice. It's your patients who will promote optometry for you rather than you trying to promote yourself. And I think that has worked out very well. So just to start off with this, I think I started off my practice in 1991. And at that time, we didn't have the kind of opportunities that you students are getting today, which is an exposure to what all is possible in optometry. In our time, there weren't any independent or maybe one or two independent optometry practices, which maybe did a lot more of contact lenses than anything else, but not real diagnostic work. So I'm here to talk to you about independent practice in urban cities. So, one second. So, once you've graduated, what do you do? I think I have the wrong presentation. Just give me 1 minute, please. Yeah, sorry, I've got this. So once your graduation is complete, what is the next step to do? So do you start an independent practice? If so, in a city or in a rural area or in a semi-urban area? So when you go to a big city, there are multiple problems. There are multiple opportunities. With every problem, there are opportunities. So the issue is that if you want to get into a niche practice, which kind of niche practice is going to suit you? And I don't think you should worry about that too much, because I think the kind of practice I do today, I don't think I ever imagined I will ever do what I'm doing today. It's just life will tell you what to do next, and you have to take those decisions as they come along. However, there are certain unique opportunities that are there in an urban environment. One of them is the fact that you have and different kinds of patient demographics compared to other areas. I'll expand on this a little bit later. And the kind of practice that you set up, today at least, is there are multiple modes. I will expand a little bit more on this. The other major opportunity that you have is that you have a lot of access to and interaction with specialists, especially I'm talking about ophthalmologists and optometrists who specialize, let's say, in optometry, for example, who specialized in binocular vision or neurooptometry, or ophthalmologists you can tie up with who are specialists in cornea, etc. These kind of interactions have multiple benefits. One is that I think when you refer a patient with a provisional diagnosis to a retina specialist, quite often they are surprised that as an optometrist, how have you reached this diagnosis when perhaps a lot of their juniors may not have reached that diagnosis, or a corneal specialist. And this in turn actually develops their faith in you. And over a period of time, they actually start interacting with you and, telling people that, you know what, I had a referral from an optometrist and it is quite an interesting case that he sent to me. So this also develops your practice to a little bit. It does also create jealousy, but that's part and parcel of it. And I think jealousy is a great thing because if that exists, that means you've done a great job. You have a lot more access to CME programs because there are more hospitals in a bigger city. Life outside practice is also a lot better. There are more restaurants to eat, more shows to go to. So as a lifestyle option, living in a city has always got some benefits. So when it comes to patient demographics, what I mean is that there is generally speaking a lot more money in an urban environment than there is not than in non-urban environments. But then I've also been traveling a lot around India into tier 2, tier 3 cities, and I do see a huge amount of expendable income that is there today. But either which way, these cities are so big today that I wouldn't really call them rural or semi-urban. I would still call them urban environments. So when you have a patient has more money, he has the ability to afford better care. So you can buy better equipment, which also increases your knowledge and increases your practice ability.
Sorry to interrupt. I don't see your slides changing.
Oh, my slides are changing. Hold on a moment. Let me just reshare my screen. Can you see it now?
Yes. Now I'm able to see. Yeah.
Okay. So please interrupt me when anything goes wrong. So when there is more money, there is better affordability for better care. In urban areas, people generally of different parts of India come to the same area again because there are more opportunities. So there is people who speak different languages. And I found language to be a huge practice builder. I'm actually a Punjabi, but I learned most of my Punjabi sitting in the clinic because I had old ladies coming in here who would invariably come with a translator. And when I could speak to them, they are the ones who actually built my practice a lot, one particular section at least. In urban areas, generally speaking, patients have got more education, they're more qualified. So you tend to find that they are more aware and therefore their needs are also a little bit more. And a lot of them require specialized care because of the kind of work that they do. So the different kinds of modes of practice that exist are people who get into practice just for the money. There are people who are more service oriented. There are people who sort of try and strike a balance between these two. You can set up a practice which is dependent, which means you do more specialty contact lenses, prosthetics, low vision aids, etc. I have a prosthetic person who comes in all the way from out of town. Every time we have a prosthetic case, he comes in. It's our way of trying to promote optometry because I think he does a great job. It's not that we can't do it. I think he does a good job, and it's a way to encourage him to continue to do his work. You can be independent, which is what we started. Today, I would say that a group practice is also very, very good because in urban areas, costs are very high, infrastructure costs are high. So you can share your costs, and it's great for people who want to do part-time work. So independent practice yesterday, in the old days, was basically a refraction. You were selling glasses, and you had some people who were contact lens specialist people. Today, you actually have multiple subspecialties. I don't have to really reiterate these, but you've got low vision aids, you've got binocular vision, you've got prosthetics, you've got keratoconus, irregular cornea, you've got developmental behavioral optometry going on, you've got vision therapy. And in addition, you've got emerging fields like neurooptometry, primary eye care, and managed care. Currently, what we do a lot of is a lot of neurooptometry and managed care. By managed care, what I mean is that we actually have, for example, a patient comes and we kind of help the patient decide when a surgery should be done, if a surgery should be done, which type of surgery should be done, and who should do it, and give them multiple options. Don't give them one option, because that, I think, is incorrect. You should tell them, well, you can go to A, B, C, and then give them the pros and cons of everything. So effectively, what you become is the family eye doctor, if I can call it, for the patient. So I have so many patients who end up giving me reports from around the world and say, this is a family member of ours who's been advised to do a surgery. What do you think? And with whatever information you have, I think it's good to do it. If I have a doubt, we sometimes send these reports out to specialist friends and they give us an opinion and we share that opinion with people. And this you may not be able to charge for this, but it really is a great practice builder. So the kind of practice challenges that you have in urban areas is that the costs can be very high. At the same time, these high costs are offset because people can afford more. So it's easy to make money on let's say, VT, vision therapy. You can charge a lot more for it. You can charge a lot more for specialized contact lenses, myopia control, whatever be it. You can offset these costs. You do have to go the extra mile to combat the competition from multinational chains, optical outlets, independent ophthalmologist institutes, and of course, online. The challenges for tomorrow for an independent practice is that this is one of my favorite lines, refraction is going to become obsolete. So if you think you can set up a practice in an urban area which does pure refraction and selling glasses, I don't know how much longer this is going to last. It is going to be a mainstay of what you do, but I don't think this is, if it's solely based on refraction, I don't think it's going to work. Multinational companies are getting in and they're going to become bigger and bigger. Chains are started. They are also going to expand their services. Online, today we have refraction apps, generic and branded eyewear, contact lenses. You are going to lose a percentage of your practice to this. Private ophthalmologists and institutes are expanding their scope of practices. A lot of them today even sell glasses. A lot of them who are not doing contact lenses today do contact lenses. So these are things that you need to do. So what are the weak links in these institutes? One is the personal connect. If you develop a personal connect with your patient, they will never leave you. They don't have time for effective communication. So one of the rules that I had when I started my practice was to spend at least 30 to 40 minutes with every single patient. Anyone can collect data today, whether it's refraction, whether it is data from a retina or pressure readings or whatever. It's how you communicate this to the patient, which, at least in my case, happens to be the biggest differentiator. It's in bigger institutes, it's not worth their time for doing vision therapy, for doing neurooptometry. Sometimes myopia control also, because the counseling takes too much time, or even for orthokeratology. Persons with special needs, a lot of institutes actually don't really look after these people with the kind of care that they need. Differentiate yourself. So for me, it was a happy accident that I started off doing CSR activities. But today, if I was to start a practice, I would say I would first start doing CSR activities, look after schools with special kids, etc. You don't make money out of it, but the kind of name you develop in the community is huge. And invariably, there'll be out of every 100 kids that you see free, there'll be one parent who will have enough money to be able to, pay off some bills, and that actually offsets your CSR activities. Evolve your practice. Practice medicine of the eye. Patients must know that you're doing a visual and a medical assessment. So do care for their general health. Talk about diabetes, talk about hypertension. Yesterday, I had a patient who had a swollen leg. So I was palpating it and seeing it. And he's like, oh, this has started 1 month ago. So I've written a referral letter to a cardiologist because it was his right leg. I said, go see it. Maybe your heart is not pumping correctly. So these are simple things that you can do. Keep up to date. Do more with the same patient. You can practice so many other things with the same patient. Just don't restrict yourself to only a refraction. Get involved with the patient. I know a lot of people say keep your distance, but I find getting involved helps. So practicing in both urban and rural settings have different benefits to offer the clinician. Knowing your own personality, your career goals and priorities, it will help you to determine whether an urban setting is a good fit for you. So basically start your practice and see how it goes. And remember, keep changing. If you don't change, you're in trouble. Thank you. And I'd love to take questions.
Thank you so much for that insight on practice in urban setups. So before any other question, Reiki, what prompted you to start your practice? Why did you want to start your practice?
But I didn't want to work for anybody. And I think my experience in Nethralaya was that I wasn't happy with multiple things there, in the sense that the kind of, you have 2 minutes to tell a patient, for example, working with a child with special needs, you would spend 1 hour, 1.5 hours with the kid, and a teacher would have accompanied the child. And, as in essence, you will dilate the patient, you'll work up the patient. Eventually, the ophthalmologist sees the retina and he tells the teacher, oh, the child has got macular degeneration. He would write a prescription which would say minus 0.75 cylinder or minus 1 cylinder, 6/60 vision, and give a prescription. This is extremely unsatisfying to me because or let's say a -1 power or a minus 1.5 spherical. The child is not going to benefit by wearing glasses. Second, the teacher doesn't know what macular degeneration means. We haven't been able to, in which way did we actually make a difference to that child's life? Whereas when you start getting involved with the kid and say, speaking to the teachers, speaking to the parents, it makes a difference. I'll give you a simple example, how I got involved with special needs kids. And this is what I learned from them. And if this is happening to them, it's happening to our patients also. We had a child who they were trying for, I think, 3-4 months to try to get the child to do eye pointing, because this was a child with cerebral palsy, quadriplegia, and only eye movements were there. They were trying to get this child to see a cup and a saucer. And at some point, this was all on telephone. I was talking to one of the teachers, and I think I just finished at SN at that time. And I just asked the parent, the teacher, what color is the cup and saucer? They said white. I said, what's the background? Oh, no, Formica table, whitish in color. So I said, just put a black chart paper, put the cup and saucer on it, and let's see what happens. And she called me back the next day, said, the principal, Poonam Natarajan, wants to meet you. So I said, why? She said, no, because what we tried to get the child to do for 3 months completely altered when you just made the background different. So this behavioral aspects, that is observing a behavior in a parent, in a patient, I think is highly predictive behavior. And it happens to every single patient of ours. I can translate this to hundreds of examples. 18-year-old girl coming in who's got one eye that doesn't move to the left. Where will she sit? She sits on the left-hand side of every single sofa, and the TV is on the right. And if a sister is sitting there, she will sit there or she will have a fight. And when you have this predictive behavior, the parents then, I've had parents cry and say, how many times we've had fights at home saying that, why do you insist on sitting on the sofa? And these are people who have gone and had that diagnosis done by hundreds of people. So I've learned from these special kids and translated that for you and me, it's very easy to understand when someone says, why do I sit on the left? But why can't we say that, do you realize that you're actually doing this? Do you realize that you don't play a sport because you're using only one eye? These are simple things for you and me, but why can't we be predictive about it? And I think that counseling, spending time with a patient is what I wanted to do. And that's one of the biggest reasons that this clinic was set up at that point. Long answer.
No. I mean, it's from the heart, and I think it conveys what a lot of us really sort of went into practice for. So there's a couple of other questions. One which said, what are the complications? I think they mean, what are the difficulties you faced when you started your independent practice initially?
Oh, 1991, there were many difficulties. We had thugs come into the clinic, sent in by a local ophthalmologist, and sad to say this. But he was surprised that I had the kind of equipment that I had. And he says, oh, he's an optometrist. How can he have all this equipment? Cut to 25 years later, for a long time, and even now we manage his practice. Because he's so it's an interesting thing. He actually got around to trusting me more than his colleagues when he got older, because we weren't taking over his practice. We said, you got a son who does this ancillary work. We'll just refract the patients and we'll send it for you, and we'll look after the eyes, but let your clinic run. But we run it under his name. It's not under ours.
Wow. Okay.
So there have been many challenges. So for example, even today, there are some retina specialists who are unhappy with the fact that we actually decide on a patient's whether they should do a therapy or they should not, because we actually give them, I think, a better pro and con discussion than they would. So it's an interesting. Every day is a new challenge.
Another one is from Larifa Kamal, who says, should we get any license to start independent practice after graduation?
I don't think there is any licensing system today. To the best of my knowledge, it doesn't exist at all. So you can start any practice that you want. But yes, remember that there are certain things that you cannot do. So please do keep that in mind, that what you can and cannot do, practice within the law. And I don't think you should ever have a problem.
There's another one which says, at the starting of independent private practice, how did you manage the money? How did you manage your money?
That was a tough one. I think I was a little lucky in it, in the sense that I had managed to get a bit of a loan from the bank and a little bit of money which my parents had given me, and we set up the practice. What did make a difference is that I did not have this foresight, but I did have exposure thanks to my father. He said, go out and see what optometry practices are like outside the country before you decide to do this. I was supposed to do a master's in Canada, and I went there and I was assessed by somebody. And within 2 days, he told me, he says, you've seen more eyes than 99% of the graduates who get out of an institute, but you don't have knowledge in certain things. So I took some short courses. And then he said, don't do a master's, because here, that time there was no clinical masters. He says, if you're a clinician, go back, start your practice. You still have to wait for your first patient. But that exposure told me how to design a clinic, how to work around in a clinic. So actually, my clinic today I haven't changed in 31 years. It's exactly wherever I thought of, I would need a plug point, I still have it. If I buy a new piece of equipment, there is a plug point for me to install it. So there was a lot of thought that went into designing the place. And that, yes, makes a difference.
Okay. There's tons of questions coming in. So I think the next question, can you start practice after bachelor's, or is master's required? I think you kind of covered in what you just spoke right now. There's just one other question, which I think is quite interesting. What are the limitations in private practice?
I don't think there's any limitation other than by law, what is covered. Obviously, you can't do surgeries. So, for example, today, we've reached to a stage today that even medication is prescribed by us, because we have ophthalmologists on our panel. So what had started off with a simple sort of a thing, see, you send a patient with, let's say, a simple conjunctivitis or with a uveitis or whatever it is. After a while, that ophthalmologist says, you know what, you already, next time you call him and say, I'm sending you a patient with a uveitis, you know what, just give him this, don't waste my time. Because they're very busy. And over a period of a few years, they actually understand that you are capable of diagnosing certain things. So most of them actually want us to prescribe, but we do make a file note and say, spoke to so-and-so, and he is prescribed this. Now, over the last few years, that speaking to them is also stopped, because we actually start off with prescription, because their name is on my letterhead. We do have them as a person who is an empaneled person. The careful thing is that where an ophthalmologist would say, come back after a week, I see them every 2 days. Because if it is sort of going a little out of control, I send them immediately to that person and say, you know what, I've done this and I'm not happy with the result. And you'll get a phone call back saying, no, I think it's okay, or it's evolved, we will alter. So they have to have your back, and that has to be a written understanding. So we do pay them a retainer just for legal purposes, to say that, yes, they are empaneled by us.
Interesting. So they are sort of on retainer.
Yes, you have to pay a certain amount as a retainer, as a legal provision, so that they are on it. So their name is on our letterhead. So even if tomorrow a case summary has to be given, if it involves a surgical process, like yesterday we had somebody or 2 days ago we had somebody who's had, I think, four Lucentis injections given in the eye. Vision came from 660 down to 6.6 or 6.9. But this was in 2012 or 13 or 14. And they wanted a case summary because somebody is going abroad and they wanted to see whether anything else can be done. So it took us a while. I wrote the case summary, sent it across to the retina guy, who then signed it, sent it back to me. And then we sent it to the patient. So these are all, I mean, these are procedural things. But there is a provision in law that you can do.
Right. I mean, I think the bottom line is having a clear understanding of what we can do and what has to be countersigned.
Correct.
And having a sort of a good working relationship with the ophthalmologist as well.
Correct.
Respect each other's boundaries, respect each other's skills, and then carry on what we're doing.
Yeah. And I think if you start getting into that cut system, that, I'll refer a patient and he'll give you some money, that is a slippery slope. Because then I think if you just refer a patient and say, you know what, that's your money, you keep it. I don't want that money. But then they actually start respecting you, because half the people today would refer for that money. And if you keep yourself away from the money, I think morally you're in a better situation. Second, I think they respect you a lot more for that after that. Absolutely
agree with you on this. Just one last question is, can contact lens practice be done independently, or should it start only with an opticals?
Oh, no. You can start an independent contact lens practice. I think one of the first ones that I had ever seen was Kamdar Opticians here. Okay, actually he had opticals also, but he was predominantly known for his contact lenses. Yashwant had started a complete contact lens practice in Nagpur. Highly successful practice. But he has evolved. He's now gone more into... so I think if you're doing orthokeratology and stuff like that, where the cornea is being potentially impacted, I think you need to have a little, personally, I would like to have a corneal specialist back up on it.
On board, yeah.
I wouldn't do it without a corneal specialist, because then potentially you can get into a lot of trouble if the cornea gets scarred.
Correct. So I think we're getting a lot more questions, and a lot of them are pretty similar stuff like, when do we start? Where do we get the money to start? And things like that. So do you want to kind of summarize that?
Yeah, so there is a separate lecture on that altogether, which is more on practice management as to how do you start, where do you get the money. So they're simple things in the sense that you cannot start a 5-star hotel as a tea kadai. So if you do want to start a full-fledged practice, you have to invest that kind of money into it. Where you get the money, what is the potentiality? It's a bit of a risk. So if you want to start in an extremely expensive street, your rentals are going to be very high, or your purchase costs are going to be very high. Now, you cannot have an expensive store and have a trial frame and trial lenses. That's not going to work. I would rather go to maybe a semi-urban area and where the rentals are a little cheaper, and start with high quality equipment, because I think equipment is what will differentiate you from somebody else. So I've used a phoropter from day one and I still use it. I still use a mechanical phoropter. I don't like using an electronic one. I'm very happy with what I've got. So there are some pieces of equipment which impress the patient, some that don't. So for example, I may have a really expensive slit lamp. That doesn't impress the patient. But if you have a phoropter, they see these bustling lenses in front and all that, it impresses them. So what impresses the patient, what doesn't, there's a whole host of things that you can do. But yes, you have to be very clear. What kind of practice do you want to do? Which kind of patients do you want to treat? And you can't treat a person, let's say you want to, sell something for 60,000 rupees. You cannot be in a small setup and try and do it. It's not going to happen.
Sure.
So you have to be very, very content with whatever you're doing. Target the demographics and work around. I mean, there's a huge topic. This is a separate topic on its own.